Welcome to Reboot with Dr. Arasi Maran. I'm your host, Dr. Arasi Maran. I have a fantastic guest for you all today. I would like to welcome Dr. Sripathi Kethu to the show. Dr. Kethu is a gastroenterologist, and not only is he a gastroenterologist, he's an author of a number one best-selling book called The IBS Guide. And he clearly has not done enough with his life. He went on to find a company called drwealthhub.com, and he's a real estate entrepreneur, an educator, an innovator, and let's not forget, he's also an ultra marathon runner. In today's episode, we're going to deep dive into all the various aspects, but focus specifically on his expertise on irritable bowel syndrome. It's a very common disease, and I would love to get Dr. Kethu's insight onto how best diagnose, manage, treat this disease. So without any further delay, welcome to the show, Dr. Kethu.
Thank you, Dr. Maran. Happy to be on the show. It's very exciting. You're doing a great job with your podcast. It's very educating and very uplifting. So thank you so much.
Thank you. Dr. Kethu, I gave a brief introduction, but I would love to hear from your own words, your journey in your medical career, your book, just tell us a little bit more about yourself.
Yeah. Like you said in the introduction, I'm a gastroenterologist. So after graduating from medical school almost 30 years ago, I went to West Indies. I practiced there in the emergency medicine for some time. And then once I came to US, I did my internal medicine residency and then gastroenterology fellowship at Brown University. And after I did my fellowship at Brown, I stayed back as full-time academic faculty there for about 5 years. So I was involved actively in clinical research, teaching fellows, teaching residents, Brown medical students. So it was a great experience. I did that for about 5 years. After that, I moved to Dallas, where I practice now. For about 18 to 19 years, I practice exclusively gastroenterologist. I don't do primary care. And within gastroenterology, there are several interests. I do interventional procedures. I do ERCP, stent placement, that kind of interventional procedures. But in the past decade or so, I got more interested in functional disorders such as irritable bowel syndrome, functional dyspepsia, because, procedure, you can fix them very easily. It as interventional cardiologist. Yes. It's very, satisfying, very gratifying to fix a, stenotic lesion or, in GI situation, GI bleeds and all that, where it's very satisfying. You fix it in an hour, you feel great. But there are a lot of underserved population in GI, that is functional gut disease, because, you can't fix it with the procedure. There is no miracle pill, miracle drug that can fix it. And they suffer more than a lot of other diseases because it affects their quality of life. So that's why I thought, because it's underserved population, there is so much need to help these patients. I got more interested and I did research, and I have a dietary supplement for them that has probiotics and some herbs to help with the irritable bowel syndrome. And last year I published my book on irritable bowel syndrome, the IBS Guide. So that's how my career transitioned from being gastroenterology for all. I'm still gastroenterologist for all, but I've been drawn into IBS because of the complexity of the disease and the need for help. Because a lot of times people with IBS, they feel ignored, that they are not being heard because it's IBS, it's all in your head. So take this pill and go home. Really, they don't get that much help. So yes. Anyway, that's how my journey into gastroenterologist and IBS came about. Um,
That's honestly the reason why this podcast also came about, because it's very gratifying to be in the cath lab, put a stent, and you're done with it. But the real work is honestly done outside the cath lab, in everyday
yes,
people's lives. And so that's how I felt like I want my impact to be more beyond the walls of the hospital, beyond the walls
yeah,
of the cath lab. And that's why the podcast came back. In that way, I think we both are aligned on trying to serve a
yes,
bigger population than the people who come to seek
yes.
us in the hospital.
Yeah,
So
yeah. Like you said, in the hospital or cath lab or GI lab or in my office, your office, you can help only one patient at a time. So you have, in 15 minutes, you may help only one patient. But, doing either writing a book, doing a podcast, doing a YouTube video, all these media will help thousands of patients, thousands of people. So
yes,
we will have
I
bigger
hope,
impact.
hopefully
Yeah.
that's the case. So
Yes.
you kind of started talking about IBS, right? And you're absolutely right. I don't think I've met there are very few women I've met in my life who have not been given a diagnosis of IBS at one point or the other, right?
Yeah.
Because they all think, oh, it's IBS, and as you said, there's no fix for it. So why don't we start off, what is irritable bowel syndrome, and start at the very beginning of what is irritable bowel syndrome.
So IBS is a functional bowel disease. Functional is where there is nothing wrong. Anatomically, there is nothing wrong. If you put a camera, if you do a scan, you don't see an abnormality. It's not like having inflammation, having an ulcer.
Ulcer,
But
yeah.
yeah, so where you do all these tests, everything is normal, but it's how they feel. That's why it's called functional gut disease or functional disorder. There are several functional disorders, IBS being one of the most common. And basically, what it means is you have a very hypersensitive digestive system. This is what I explain to my patients. Where you have a very touchy, sensitive digestive system, it reacts to anything and everything. So it can be stress, either mental or physical stress. It can be what you're eating, what you're drinking. All those will affect this functional gut disease. With IBS, because they have a sensitive gut, they can have all kinds of symptoms. That'll be mainly abdominal pain is one of them. Other than
Hmm.
abdominal pain, either diarrhea or constipation. Sometimes they alternate between diarrhea and constipation. Another significant symptom is bloating. A lot of people feel so bloated. That's one of their number one complaints. And like you said, you have not seen any woman who was not diagnosed with IBS, because unfortunately in women it's a lot more common. But generally, if you take the general population, if you take, depending on what country you look at, what study, how vigorously they have done the study, the prevalence of IBS is anywhere from 20 to 35 or 40%. In Western world, it's more. Probably it's being diagnosed more. It's not that it's not there in developing world, but so basically about one third of the entire world population has IBS. So one in three. So if there is another person in this room, that will make us three. So one of us
One of
may
us.
have IBS. It's that common. And like I said, because of those symptoms, their quality of life is very poor, because they're always anxious about what they can eat, what they can drink, where they can sit when they're eating, and how close their bathroom is, because it's so unpredictable. It might sound like, oh, it's not a big deal, it's just going to the bathroom. But I think people who have that IBS, because their life revolves around their gut symptoms and what they can eat and all that, it impacts their life on a daily basis.
And eating is such a social thing. We go out for lunches or dinners. Our family get-togethers are focused on eating, and to
Yeah.
be anxious about eating is a curse. It cannot be,
Exactly. Unless you're in that situation, you won't know, because a lot of simple pleasures that we take it for granted. But unless you're in that situation, you won't know it. Yeah, just simple meal with friends and family, going out can be such a big chore where they have to plan everything, and they have to plan what they can eat, when they can go out, how they are feeling that evening. So many things will come into play.
Absolutely. Okay, so let's say we have a person who's come to you and says, all I have ABC, etc., and you think, okay, are there any lab tests you can do to diagnose IBS? How does the diagnosis happen?
Yeah, I think unintentionally you already mentioned ABC. Those are the symptoms, believe it or not.
Okay.
Abdominal pain, bloating, and constipation. And there is a D, which is diarrhea. So
Mm,
ABCD. Okay.
okay.
So you hit it right there. Uh, those are the symptoms we look for. People usually come in with generally abdominal pain. Uh, when they have abdominal pain, that's what our task is to tease out what it can be. It can be as bad as having cancer, appendicitis, cholecystitis, or it could be as simple as IBS. I'm not saying IBS is simple, but it's not life threatening. Even if you
Yes.
miss a diagnosis for a day or a week, it's not going to kill a patient. But
Yes.
it is a big deal.
But it's a
So when
nuisance disease. From what you're telling me, it's a nuisance disease. It's not
yes,
a life killing disease. It's not a fatal disease, but it's a nuisance disease.
exactly. That's exactly right. So when patients come in, these are usual symptoms they have. And it doesn't mean that we have to do every test under the sun to make a diagnosis of IBS. We have a typical profile. Young patients generally tend to be women, but there are a lot of men who have IBS. And these are the typical symptoms: abdominal pain, bloating, constipation, diarrhea. And then we ask, what are the other symptoms they have? What we call, as you know, in medicine, there are red flag symptoms. So, do they have any red flag symptoms? In this situation, we ask them if they have any weight loss. That makes a big difference. If they have significant weight loss, IBS never does that. So your trajectory, how you work up, will be completely different. If they have any fever, they have any chills, if they have any other associated symptoms, nausea, vomiting, do they have any family history of either cancer, IBS? That also makes us, narrow down the diagnosis. And sometimes we do blood tests based on that. Age is another factor. For example, like I said, young patient comes in, 20-year-old, they've had these symptoms for 2 or 3 years. Then we may not need to do a lot of workup. We make a diagnosis because there are criteria called Rome criteria. Now, they have Rome 1, Rome 2. Now, and they have revisions every 5 to 6 years. Based on Rome criteria, we can make a diagnosis without doing any test at all, or maybe minimal test, maybe a blood test, or sometimes we don't even need to do that. So when we do that, based on that, we can decide what is the diagnosis. But for example, if there is a 50-year-old comes in with exactly the same symptoms, and if they have the same symptoms, but because they're older, and if they have symptoms, recent onset of symptoms in an older person will, require a lot more work, because it can be something more serious. So new onset of symptoms in older person with or without associated red flags will require more testing. We may do blood count, we may do sometimes ESR or CRP, C-reactive protein, to see if there is any evidence of inflammation in the body. And let's say if they have family history of celiac disease, I might do a celiac profile, celiac antibodies, which is gluten sensitivity. Sometimes we do a stool test called fecal calprotectin. That is the marker for inflammation in the gut.
Mm.
Depending on what kind of symptoms, we might do a calprotectin. That's a basic stool test. And if it is abnormal, then probably it's not IBS. We are dealing with some kind of gut inflammation that might prompt us to do a colonoscopy, for example, to rule out Crohn's disease, ulcerative colitis. They're called inflammatory bowel disease. They're not IBS. People get confused between
Yes.
IBS and IBD. Even in medical field, people get confused because, IBS and IBD sound so similar. Some of even my doctor colleagues, sometimes they say, patient's family has IBD, but when you talk to them, they actually have family history of IBS. Big difference. They sound the same.
So I'm going to summarize what you basically said. So for irritable bowel syndrome, IBS, the symptoms can be very simple diagnosis of abdominal pain, bloating,
Mhm.
constipation, diarrhea. And the diagnosis is most of the time based on a clinical discussion and physical examination. And in the absence of red flags and based on the age, testing, the next step of testing can vary. Am I correct?
That is exactly correct.
So the symptoms can be very simple, and it's most of the time it's ruling out life-threatening diseases such as cancer or inflammatory bowel disease (IBD), which can be Crohn's or ulcerative colitis. Am I correct?
That is correct. Yes.
Okay. So let's say you've made the diagnosis of IBS in a patient. Okay.
Yeah.
What is the first thing they have to do?
So first thing, I think as physicians, what we have to do is reassure them, because because it's a brain gut disorder, which we will dive into in a minute. A lot of times the anxiety about their symptoms will cause more symptoms. So breaking that cycle, because it's brain gut disorder, when you're anxious your gut will react, and when gut reacts you will be so anxious. That's why you're with your gastroenterologist. So you need to break that cycle. The first thing I do is reassurance. Like I said before, it is a very common condition. It never kills anyone. So if you tell them those two things, I think 20% of the treatment is already done.
Mm-hmm.
Because a lot of times they feel so much better once we reassure them. They might even say, okay, that's great. I've been having these symptoms for so long, and I've been to all these doctors. No one really said anything. They never mentioned IBS at all. They just said, okay, you have bloating. Okay, take this medication or do this test and do this CAT scan and all that. They've been running around between doctors without a diagnosis. Once they have a name, they know that this is something. This is not all in their head. There is a name to it. Once they have a name, they feel so much better. Okay, now I know what I'm dealing with. If I need medication, I'll come back to you. If I need more tests, I will come back to you. So just the reassurance will be such a big part of the treatment. Other than that, next most important thing, I'm not a big fan of using medications for IBS because one, it's a lifelong condition. It's not practical for a 20-year-old girl who is in college, busy with her studies and all that, having her to take medications, dealing with the side effects, doing all kinds of tests, taking time off from college to do all this. It's not practical. It's not necessary. It's expensive too. So first thing is I want to make it more naturally. So what I do is talk about diet. I go through their dietary habits, which is also challenging when you're a 20-year-old in college, talking about, fixing their diet, eating better, not drink your Starbucks and all that. That's not that easy, but that's the most important. So when I tell them that I can fix your symptoms or at least control the symptoms, there is no cure. That is another thing I make it very clear. There is no cure for IBS. It's like any chronic condition. There is no cure for hypertension. There is no cure for diabetes yet. There is no cure for IBS. But the good thing is hypertension and diabetes can kill you, but IBS never kills you. That is the good thing. Both all are chronic conditions. But once I tell them that there is no cure, because I don't want them to have over expectation where, this doctor knows all about IBS, he's going to cure me. I have to set the expectations right. Diet is probably the most important thing that we have to discuss. So after reassurance, the next thing is to talk about diet. Like I said earlier, treating it naturally is the best way to do it because you can follow that long term. Medications is not practical. So when it comes to diet, I go through their dietary habits to see what they're eating, if there are any triggers, have they even tried eliminating certain foods to see if that helped. If they have not done that, that is the first thing. Some people may be sensitive to lactose. It's very common, especially in African Americans and certain ethnicities. Lactose intolerance is very common. So their symptoms could be just lactose intolerance, or lactose intolerance may be contributing to their symptoms on top of IBS, because IBS can exist with other conditions. They
Mm-hmm.
can still have IBD, they can still have celiac, they can still have lactose intolerance, they can have celiac, they can have other conditions. So I go through their diet and to see if they have any triggers. And I always tell them, when we talk about diet, I tell them to write down a food diary, food journal,
Mm, I was
at
about
least
to
for
ask
2
you
weeks.
that. Yeah.
Yeah. So that's very, very important, because you can identify something simple. I hear patients tell me, no, I have not changed my diet for 30 years. I eat exactly the same thing every day. But your body is not the same. Your diet is the same, but your body might have changed, where you might have developed sensitivity, especially lactose. Even if you don't have it before, as we get older, all of us develop some sort of lactose intolerance. So it may be simple thing like, I have some older patients who like to eat ice cream every night before going to bed. That's their simple pleasure. But just eliminating, I tell them, just stop eating ice cream. They don't like my advice, but doing it just for a week is enough. They will be very unhappy not eating ice cream. They'll be very happy with the symptoms resolution they're going to have. So I have to convince them, I have to bargain, and I have to give and take to do that. But so dietary elimination. So writing a food journal to identify the triggers. If it is not lactose, sometimes it could be gluten. They don't need to have celiac disease, which is a genetic condition where you have severe intolerance or allergy to gluten, but you may have mild intolerance to gluten. A lot of people have gluten sensitivity, not celiac disease. So you need to identify that population to see if they're eating a lot of bread and pasta. Maybe that's
Mm-hmm.
their problem. So going into their dietary habits, sometimes even high sugar, if they're drinking a lot of sugary drinks, I talked about Starbucks drinks, or
Starbucks.
Coke, all the sugary drinks, that changes your gut microbiome. So all that processed foods can affect their symptoms. So changing the diet, probably 30 to 40% will feel better. So that's so easy, and you can follow it long term. So
Now, does ultra processed foods we have, right? All I mean, especially young college kids are living off micro McDonald's and Chick-fil-A and Wendy's. Does that have a direct relationship with IBS, direct or indirect relationship with for IBS?
yes, for sure. Because there are a lot of studies showing that when you eat ultra processed foods, ultra processed meats, sugar, all that, it'll change your gut microbiome. Now, microbiome is the next big thing in medicine.
Yes.
Everybody talks about, even in your field, cardiology, you name it. It's almost like deja vu for, vitamin D used to be the cause of everything, and
Everything.
the fix for everything. Now no one talks about vitamin D as much, because now there is another good thing they can talk about. That's microbiome. But there is so much research behind microbiome, because gut microbiome, which is basically, just to go into the basics, it's the bacteria in your gut. There are billions and trillions of bacteria in all our guts. There is If there is imbalance, there are some good bacteria, there are bad bacteria, there are fungi, there are yeast, there are other things that as part of the gut microbiome, but bacteria makes probably 80 to 90% of the gut microbiome. If there is imbalance between good and bad bacteria, it will cause your IBS symptoms. I will touch on that a little bit later, why
Yes.
it affects it. But going back to ultra processed foods, these will cause what we call leaky gut. So, leaky gut is a controversial topic, so I'm not going to legitimize it, or I'm not going to say that that's real, but there is some data. Leaky gut is very misused term on the internet by natural practitioners, everyone. Uh, but there is some evidence that leaky gut is something there, where you have these tight junctions between your cells, your lining of the gut. So if those junctions, if they're not tight enough, you can leak into that gaps. You can leak some toxins and all that can go into your bloodstream, that can cause chronic inflammation, a lot of different conditions. It can also cause IBS. So that is one theory behind why you should not eat processed foods, because it will affect your gut microbiome, thereby affecting, maybe causing leaky gut, affecting your tight junctions. It can not only cause IBS symptoms, but other systemic illnesses, anything that's involved in inflammation.
So let's talk about, there are two great things you talked about. One is maintaining a food diary. So does dietary changes, does changing the diet alone, um, can that alone be enough to manage IBS?
Absolutely. Yes. Because, some people have something that they're eating all the time and they don't even realize that that's actually causing symptoms. Like I said, I have some patients just eliminating ice cream at bedtime, that fixed their symptoms. They didn't even realize. So there are different food triggers when it comes to IBS. This is what I tell them: your gut has its own mind. Every gut is different. Figure out what your gut is thinking, figure out what your gut is not liking. So if you identify the triggers, that's why we call it elimination diet. You
Hmm.
eliminate one food category at a time to see how much relief you're going to have. That's the most important thing. A lot of times, that's all I tell them. Some people may not be happy. I saw this doctor, he didn't do any tests, and then he just said, follow this diet, and he sent me home. He didn't write any prescription. But I'm trying to help them because I don't want them to take medications. I don't
Absolutely.
want them to have multi-million dollar tests. But anyway, so yeah, diet can fix a lot of symptoms. Other than elimination diet, there are other diets. There is fermented foods. Some people may have relief. There is something called low FODMAP diet. That's a very popular science-based diet. There are multiple studies out there showing that low FODMAP diet helps, but no size fits all. It may not help everyone, but that is something that I use a lot in my practice.
So can you elaborate a little
Yeah,
bit about FODMAP,
yeah.
FODMAP, that's a diet?
So FODMAP, uh, FODMAP stands for different carbohydrates. It's not protein in our diet. It's not fats in our diet. FOD stands for fructooligosaccharides, disaccharides, monosaccharides, and polyols. So these are different sugars, different carbohydrates that we consume in our regular diet. So, for example, lactose is one of them. Even simple eating an apple. People think that eating an apple keeps your
Keeps your
doctors away.
doctor away.
It might keep your doctors away, but it may not keep your symptoms away. It might even cause symptoms. So, galactose in apple can cause symptoms because it's a carbohydrate. Some people may not be able to digest. So these FODMAPs. Some people have harder time digesting these FODMAPs. So diet that has low in these FODMAPs, these carbohydrates, will help the symptoms. And this idea came from Australian scientists. They came up with this low FODMAP diet protocol, and they published first study several years ago. And since then, there are multiple studies showing that these results can be replicated. And low FODMAP diet now has become almost a standard. If anyone talks about diet for IBS, it is the low FODMAP diet everybody talks about. But like I said earlier, no size fits all. Although low FODMAP diet is there, it may not help 100% of patients. It may be something even simpler than that. It may be too much caffeine that they're drinking that may be causing the symptoms. So I think, a lot of times spending time with the patient, that is the most important thing. Listening to them will achieve two things. One, they feel heard. They'll be very happy that someone is listening to you. Second, it's helping you too, because just listening to them, you can formulate a plan. You don't need to do, you don't have to think a lot. They're giving you all the ideas. You just have to process that information and come up with a diagnosis. So listening to them is the most important thing.
So another thing which you talked about is the gut bacteria, right? And as you
Yeah.
said, there's so much, like it's the hot topic right now. And I see, even when I walk into like our regular pharmacy of CVS and Walgreens and blah blah blah, this $600, $700 testing for, like, you send your stool sample and it gives you all the bacteria in your stools, and it tells you what kind of sensitivity you have, etc. What is the validity of those tests, and do you use them?
I don't use them. There is some validity, but we are in a very early stage of testing gut microbiome. So what they do is they do PCR testing. You send stool sample, and it's cash paid. Insurance doesn't cover it yet
Mm-hmm.
because it's not a standard. There are so many companies now. They give you a report. I think in allopathic medicine, in modern medicine, we are not using it because it has not become a standard, because there are not studies, because we follow evidence based medicine. So there is evidence but not good enough evidence to make it a standard test yet. But natural practitioner who practice natural medicine, functional medicine, those practitioners have been using this gut microbiome test. There is, I think it's called GI map study, where
Mm-hmm.
they test like 200 different bacteria, fungi, viruses, everything. They give you a report. Based on that, they'll say, okay, your gut microbiome, these are the bad bacteria you have. This is what you need to do. So the short answer is I don't do it. I don't think it is a standard yet, because each company offers different plants. They check for different bacteria. They use different techniques. So we don't know what is standard yet. But gut microbiome itself, because there is so much interest, I think altering gut microbiome is definitely real. But how you alter, what kind of tests you need to do to figure that out is still in its infancy.
So, Dr. Ketu, a simple question. Like you, I am not a person who likes to take a whole bunch of medicines. And even every time a patient comes to me, I'm trying to, like, no, we can take this off, take this off, take this off.
Yes.
So, as a simplistic person, I mean, this is a person who uses, 5 different atherectomy catheters to modify calcium in the lab, but in clinic, it's a different mechanism. The less is more concept. So, to
Yes.
alter the gut microbacteria, it's all our diet. So
Yeah.
wouldn't we be better off, instead of spending this 500, 600, $700 on these fancy tests, actually taking, as you said, maintaining a food diary, or changing our diet accordingly, or just eating real food, eating vegetables and natural proteins, and avoiding high sugary foods? Wouldn't that be the simpler way, or is that the simpler way of doing it?
Absolutely. It's not only simple and but is the best way to do it. Because test is not going to fix your problem. Test may actually cause more anxiety, because you have done this test, they bring that report. Whoever ordered it, you can even order it online. You don't
On
even need
Yes.
a doctor. So they spend this $1,000, they get this elaborate report with 200 different microorganisms. This is positive, this is negative. Now they have anxiety because there are a lot of things that are positive. They have no idea what it is. They don't know how to interpret. Now they spent $1,200 and bought their anxiety by paying that $1,200. And then they bring that report to you. You don't even know what to do with it, because these are all the bacteria you're supposed to have. But can I say that this one bacteria that is positive is causing all your symptoms? I don't know, because it's
We
all
don't
about the
have
balance.
evidence.
Yeah,
Hmm.
when you have trillion bacteria, how can I tell that, okay, this is it, and I'm going to give you antibiotic to kill this bacteria, eliminate your problem forever? I can't do that. So it just causes more anxiety. And it's not even a long-term solution. So the long-term solution would be fix your gut microbiome by changing your diet, your lifestyle, what you're eating. Those are the three things that will help a lot. So coming to the diet, like I said, two things: processed foods and high sugary foods. These are the two things. When I say processed foods, processed meats, for example, salami or bacon, all those are processed foods. And then sugary foods, which are unfortunately very common, all the desserts, all the sugary drinks, those will affect your gut microbiome. Just changing that will fix your gut microbiome. And then
Absolutely.
managing stress, we don't recognize how important it is, but stress can affect your gut microbiome. It's not just diet or what you drink. Just managing the stress will alter your gut microbiome. that is more a basic solution, because when you're fixing gut microbiome, you're not only fixing your IBS, your gut problems, but you're fixing the whole body. Like I said earlier, now there is so much research, right from mental conditions like anxiety and depression to dementia, Alzheimer's disease, cardiac disease, endocrine, thyroid disease, all the autoimmune conditions. A big part of autoimmune conditions can be brought on, because autoimmune conditions, it's not like an infection, something is triggering it. I think you may have genetic predisposition because of your family history, you may be prone to have autoimmune condition, but unless there is a trigger, you may not have it. That trigger may be in the microbiome, so fixing it will fix a lot of other problems.
You were talking about fixing stress, etc. How about cognitive behavioral therapy? Is there a role in CBT or cognitive behavioral therapy for IBS?
Oh, yes. I think, I wrote a chapter on CBT in my book, The IBS Guide. There is a lot of data showing that cognitive behavioral therapy helps. The problem with CBT is there are not enough providers to administer CBT. That is the problem, that even being in this field, I'm encountering that problem, because not all psychologists or therapists are comfortable managing or administering or doing CBT. Not all of them, even if they do CBT, they may do a generic CBT. They may not do it that'll help IBS. So they need to tailor it, tailor to the needs of the patient, their symptoms, what are the triggers and all that. But if someone can find a therapist or a psychologist who is very comfortable doing CBT, especially if they have experience with patients with IBS, I think that helps so much. And there is a lot of research showing that CBT can be a game changer if it's administered properly.
You know, it's I'm a big follower of the Calm app and the Headspace
Yes,
app and Waking Up app, etc. I mean, I'm not getting any money from any of these apps, but I follow them because I personally use them, and they have a little thing for anxiety issues or gut issues, and that might be a good place to start, just to
absolutely.
try
Yes.
some
Yes,
mindfulness therapy.
yes. So that's what I tell my patients, because trying to find a local psychologist or therapist, especially if they're living in a small place, they may not even have access, and there is always a long wait to see a therapist. Even if they see therapists, it may not suit their personality, or they may not do what they're looking for. So apps, actually, Calm and Headspace are the two apps I recommend to my patients
Yes.
for CBT. There is another app, is it's called Nerva, Nerva.
Yes, I have seen
Nerva.
that one too. Yes.
Yeah. So what they do is they do hypnotherapy. It's not CBT. Even hypnotherapy, there are studies showing that they help. So Nerva administers hypnotherapy, and it's also, it's a paid app. You pay subscription for 4 months. I think it's a limited subscription, and they published a study. The Nerva app, whoever came up with it, it's also from Australia. So they published a couple of studies showing that their app works.
Mm.
But like I said, there is no magic pill here. You have to try a few different things. But like I said, diet is simple, inexpensive, easily doable, everything in your hands.
Yes.
If you don't have relief, or if you're not able to do it for any reason, then other things come into the picture. Stress management is important, CBT, hypnotherapy. Sometimes I tell them to just do meditation with Calm or
Mhm.
Headspace, because you don't even need to do as fancy as CBT, just meditation every day. Again, there are studies showing that simple meditation for 5 minutes a day will help your IBS symptoms because it calms down your brain and gut.
Absolutely. I mean, there's meditation has come like, so many different unrefutable science
Yeah.
that meditation, or if you don't want to call it meditation, but call it mindfulness practice, makes a big difference overall. Now, let's move to like, we've talked about diet and mindfulness, something I think we both completely align on. Even for heart disease, I think it's the same
Yeah.
thing, stress management and eat well. How about let's talk about medications? Are there medications which help control, or what is the role of pharmaceutical therapy in IBS?
There are many medications available for IBS. Depending on the symptoms, there are one of the basic categories antispasmodics, because we think that irritable bowel syndrome, you have the spasm of the colon. That's why in the olden days it used to be called spastic colon,
Hmm.
because their main symptom, abdominal pain or bloating, is because of the spasm of the colon. There are medications that will relieve that spasm. They are called antispasmodics. There is one called dicyclamine, there is hyoscyamine. So antispasmodics are basic old drugs. People use it all the time. When you look at the studies, there are not that many studies showing that they help, but they're better than nothing. That is the basic category. And then there are newer medications that they are fancier, and they help alter the gut motility. It will also affect your gut brain communication. So they help not only just abdominal pain, antispasmodics, they just help the abdominal pain. There are medications. There is one called Linzess that's used for IBS with constipation, where it helps not only constipation, but it helps the abdominal pain, bloating, other symptoms of IBS. There are several drugs out there. I'm a minimalist when it comes to medication. I still use a lot of medications, because the amount of IBS patients we see in GI practice, any GI practice, not just my practice, any GI practice, IBS patients are so common. They're out there seeking help. Some of them, they already saw their primary care, or they already found something on the internet. They tried diet. By the time they come to us, they may have already tried few different things. So those are the patients. I can't tell them just follow the same diet, or let's try low FODMAP diet. They're actually wanting medications because they already tried all that. Those are the patients. I might start them on medication on their first visit, because that's what they
They've
want. They
tried
want
out.
quick relief. They're tired of having these symptoms for so long. So there are different medications, but we need to weigh the risk and benefit. If the side effects are more than your symptoms, obviously it's not worth it. There are
Absolutely.
certain medications, especially antispasmodics. If I have older patients, if I use antispasmodics, they may have more symptoms, more side effects. We call it anticholinergic side effects. They may have dry mouth, they may have dry eyes. Some people call you and say that I'm blurry. I think I'm losing my vision. All they have is just dryness of their eye because of this
The
medication.
medicine.
It can make them sleepy. So if it makes you sleepy, and you can't work, and if it affects your quality of life, relieving your symptoms is not going to be really helpful.
So, we talk about the gut microbiome, etc. I think this podcast will not be complete if I don't talk about fecal transplant, and
Yes.
that's become another big hot topic, like vitamin D and everything else right now. People are really talk. I mean, there was a show on Netflix where they talk about this, and someone did a DIY, do it yourself
Yep.
fecal transplantation, and I was like, oh my god,
I know.
what have this world
Yeah.
come to?
Yes.
And I mean, I'm not saying there's no evidence. There is evidence for
Oh,
patients with
yes.
C. diff, and there's growing evidence on obesity, etc. But what is the role of fecal transplantation in IBS? Do we have
Short
enough
answer
evidence?
is short answer is it doesn't work. Not yet. I think probably we need to fine tune the treatment. I think there is a role for IBS, as you said. For C. diff, it's irrefutable evidence. There are thousands of studies. It's a life-saving treatment for
Hmm.
patients with C. diff, because all these hospitalized elderly nursing home patients who have C. diff, you try all kinds of medication. Now they have toxic megacolon. You're at a point where taking them for surgery, they're going to die faster. If you don't take them to surgery, they'll still die. They don't have much option at all. Those are the patients. Now we can save their lives. Not only older patients, anyone with C. diff that's not responding to antibiotic, or if they have recurrent C. diff, giving them fecal transplant will save their lives. So in C. diff, there is so much evidence. But when it comes to other conditions, whether it's IBS or IBD, Crohn's or ulcerative colitis, there are a lot of studies, but they are not as effective as how it works for C. diff yet. That's why I say I think probably there is a role to alter the microbiome, but I think we may have to change the way we select the donor. To maybe we need to profile the donor. Maybe it's doing one of those fancy gut microbiome tests of the donor to see if they have a favorable bacteria that'll help the IBS. So I think there is a role, but we are at early stages right now. It's not standard. We never offer. We don't recommend it. It's not a good idea to do it for IBS.
And how about exercise? I mean, we talked about changing your diet. How about exercise? Does it help with the symptom control?
Yeah, I think
Or are they
probably
too scared to go exercise because of their symptoms?
I have a feeling probably you talked to one of my patients because you're hitting all the things that I tell patients. So absolutely. So after the diet, after talking about meditation, yoga, mind gut relaxation, and therapies, exercise is big part of me because as an athlete, as a runner, already I am into fitness and running and all that. But I don't want to torture my patients and tell them to run like I do. But exercise, there are a lot of studies. So when it comes to exercise, it relaxes your brain and gut. So there is a big role. This is what I tell my patients. If you're able to exercise, you're young and fit, go for a run. Don't go for a walk. You need to be able to sweat and not able to walk. I mean, talk when you're doing an exercise. You should be out of breath. You should be sweating. If you're 20-year-old and go for a walk for an hour, it's not going to do anything. Yeah, it may be better than sitting on the couch, but a vigorous exercise will release the endorphins, all the happy hormones that will relax your gut and brain. So aerobic exercise is a big part of what I recommend for young patients. If there are older patients or if they have other conditions where they're not able to exercise, simple yoga.
Older people exercising.
Older people, when they're not able to exercise, if they cannot, run or jog, I tell them to do something simple like yoga. Again, going back to science, there are studies showing that yoga helps IBS. Not any condition. I mean, there are a lot of other conditions yoga helps, but specifically in IBS, there are studies showing it. So I tell them to do simple stretches and yoga. They can watch YouTube video and do it maybe 3 or 4 times a week. That'll help, just 15-20 minutes of yoga. So exercise is big part of the treatment. That's why I say, when I say I treat my patients naturally, other than the medication, it's the diet, mind, body, relaxation, exercise. Those are the three most important things. And when it comes to managing stress, let's say if they have underlying condition like anxiety or depression that are either undiagnosed or untreated, they need to be fixed, because that may be the issue. It may not even be the IBS. It may not be nothing wrong with the gut. It's the brain that's not happy. So once you make the brain happy, your gut will be happy. So I tell them, yeah, I can do all kinds of medications. I can give you all kinds of prescriptions that are available for IBS, but it may not fix your IBS until we fix your underlying issue, which is your anxiety or depression.
I think sometimes, I mean, am I correct in saying most of the time the IBS patient population seem to be the unheard population? Nobody listens to them. And therefore, their symptoms get unnoticed, untreated, and that kind of gives rise to more other organ systems being involved in their disease process.
Yes, actually, so going back to anxiety and depression, although anxiety and depression can cause IBS, untreated IBS, even if they don't have anxiety and depression before, can lead to anxiety and depression. That's one of the things that can happen when you have IBS. And there are other things, it can affect their work life, their personal life. So it can affect a lot of different things. So, and like I
Absolutely. I
said,
mean, go ahead, please.
so yeah, because they're ignored by medical community in general. So if you address those concerns, I think there'll be a lot of happy patients.
So, if you have to give like five pieces of advice to anyone who is listening to this podcast,
Mhm.
and they are probably thinking, oh, I do have this, I do have bloating, I do have abdominal pain. What would be the top easy five things you would advise them to do?
First thing is how long they have had these symptoms if they have been evaluated by a doctor, because don't self-diagnose. That is the most important thing, because there is so much information on Google, on the internet. So you don't know how, I shouldn't say you don't know, but they may not have the medical training or knowledge to process all that information to make a diagnosis. So don't self-diagnose. Go to your physician or your provider to have a formal diagnosis, especially if your symptoms are new onset. Once you have the diagnosis, that is the first step. Second thing is diet, managing the diet. So that is the most important thing. Third thing is managing their anxiety and stress. Okay. And fourth thing is exercise. Okay. Those are the four things I recommend. And fifth thing can be depending on what these four things will, achieve. It can be medication. It can be something totally different. Maybe it's not even IBS. We may be looking at the wrong, in the wrong direction. So always have open mind. See if there is something else that's causing you problem.
Absolutely. You know, the title of the show is called Reboot with Dr. Arasi Maran, and we have discussed so much about IBS, and we've touched everything, all the, conservative therapy to medication therapy to diet, exercise, everything. So now I would like for you to share your story, your own personal reboot journey, and I want please tell us
Okay.
what happened and how did you get to where you are right now with your rebooting.
So, I think more than reboot, I think there are a lot of resets, I should say. I don't think there is one particular life changing moment that rebooted my whole life, but there are a lot of resets. One example, I think probably one of the best examples is when I was in my early 40s. I was working so hard. There was no work life balance. I was working probably 12 hours every day, 6 days a week, 70 to 80 hours a week, taking so much call, ignoring my health and my mental and physical health. That was my reset moment, because one day I was thinking, I thought I was fairly physically fit because I used to play basketball and tennis. I thought I was physically fit, but one day I went for a run. I'm not, I hate running. I was never a runner. One of my friends in the neighborhood, he said, I'm going for a walk, and maybe we can run for some time. Do you want to join? I thought it's going to be just for a walk. I went with him, and then he said, okay, let's just run because weather is nice. It's on a track. So he said, let's run. I could not even run quarter mile. So then I realized how unfit I was. Although I thought I was fit, I never tested myself. That was a sort of a reset moment where I was thinking, okay, maybe I need to focus on things that are even more important for me, for my young family. That's when I started, okay, maybe I should do something. I got into running. Like I said, I hated running just to prove that I can at least run 1 mile, because I failed yesterday, not even be able to run quarter mile. I thought, okay, I have to pick up running. If I run at least 1 mile without stopping, I'll stop running. I'll be very happy. That's all I needed to do. I had a simple goal. That's how it started. But with running, it's an addiction. Once you run 1 mile, you want to run 2 miles, then you want to run 5 miles. Before you know it, you sign up for a 10K, then half marathon, then marathon. Now it's 100 marathons. That's how many I've run, 98 to be exact. So that's how my reset moment started, my running journey started. I think it's very important, especially as physicians, we are at a position where we need to lead the way. We need to show them, if I'm overweight and doesn't exercise, I'm a smoker, coming in with smoking, smell, and then I am obese, coming into the patient's room and tell them, you need to lose weight, you have to stop smoking. That's not the way. You need to lead the way. So
Yeah.
I want to be a role model for my patients, where when I tell them to exercise, I'm telling from the person who has done that, who has done a lot
Yes.
of it with experience. People will listen when you tell them when you're doing what you do, they will take it more seriously. So that's why I think, even when it comes to diet, I tell them what I eat. So that they will know that, it's easy to do it, even if we have busy lifestyle. A lot of times patients will say, I'm so busy, I pick up fast food. I tell them I'm busy too, but I don't eat fast food. So if there is a will, there is a way.
Absolutely. I mean, that's absolutely true, right? You are probably the third doctor who sat across from me and have talked about the 40s. And, and the same thing with me. When I turned 40, I looked in the mirror and said, oh my God, I need to fix A, B, C, and D, and got on my journey. Unlike you runners, I can't run. My hips do not allow me to run.
Yeah,
so
yeah.
I get on my bike. I'm more of a biker, and, I love the biking journey. And Dr. Kethu, thank you so much. I know there's a India-South Africa match happening right now, and you're taking time away from that and talking to me. So thank you. And it was very educational, and I learned so much. And, and it's very refreshing to see another doctor who says, just fix your diet, take time to meditate, take time to exercise, and that can give you a whole world of benefit instead of depending on expensive tests or expensive medications. There are simple things we can do to make our lives better. And thank you so much. And I truly appreciate your time.
Thank you so much. Happy to be talking to you.
Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.